Clinical Case Vignettes, Urology and Nephrology Review.
A male patient presents with lower urinary tract symptoms, an enlarged prostate, but a normal PSA of 3.8 nanograms per milliliter. A transurethral resection of the prostate, or TURP, is performed. Histology shows a Gleason 9 adenocarcinoma in 8 of the 48 total chips retrieved. What is the clinical T stage? A. T1A, B. T1B, C. T1C, D. T2A, or E. T2B? The correct answer is B. T1B.
Okay, let's dive into this. The reason it's T1B all comes down to the math. T1B denotes the incidental discovery of a tumor during a benign resection, specifically where the tumor volume makes up more than 5% of the resected tissue. 8 out of 48 chips is roughly 16.7%, which easily crosses that 5% threshold. For your exam pearls, just remember that T1A is 5% or less. And if you're wondering about T1C, that's when a tumor is discovered via needle biopsy prompted purely by an elevated PSA, usually with a completely normal physical exam.
A 50-year-old man comes in with a high fever and severe perineal pain. A digital rectal examination elicits exquisite severe tenderness. Urinalysis confirms a bacterial infection. The absolute most common causative pathogen: A. Staphylococcus aureus, B. Pseudomonas aeruginosa, C. Streptococcus faecalis, D. Bacteroides fragilis, or E. Escherichia coli. It's E. Escherichia coli.
This presentation is the classic signature of acute bacterial prostatitis. Basically, gram-negative enterics ascend right from the urethra, and E. coli alone accounts for a massive 80% of all these cases. Now pay very close attention to this clinical warning. Vigorous DRE, or prostatic massage, is strictly contraindicated in these patients. It can literally force bacteria into the venous plexus and precipitate acute septic shock. You absolutely don't want that. These patients require immediate broad-spectrum antibiotics for a minimum course of 3 to 4 weeks to guarantee deep tissue penetration.
What is the most appropriate immediate next step for a patient diagnosed with an acute prostatic abscess? A. Empirical oral antibiotics, B. Delayed prostatectomy, C. Vigorous prostatic massages, D. Elective TURP, or E. Transrectal drainage without delay. The correct move is E. Transrectal drainage without delay.
Once standard prostatitis escalates and a localized abscess forms, systemic antibiotics just cannot penetrate that necrotic core. Physical drainage is literally the only viable option to clear out the purulent material. On a DRE, this is going to feel like a localized, fluctuant, boggy area. Transrectal ultrasound-guided or truss-guided needle aspiration is highly favored here. It's minimally invasive and totally avoids the massive tissue risks of attempting a transurethral resection in an acutely septic field.
A 30-year-old male complains of progressive urinary frequency, weight loss, evening fevers, and a dull loin ache. An IVP shows rigid standing-up calluses. What's the next best step? A. Cystoscopy, B. CT-QB, C. Ultrasound, D. Early morning urine microscopy and culture, or E. X-ray. The key diagnostic action is D. Early morning urine microscopy and culture.
This whole subacute constellation of constitutional symptoms is highly suspicious for genitourinary tuberculosis, or GUTB. The absolute gold standard diagnostic step is collecting 3 consecutive early morning urine specimens for AFB staining and specialized culture. And this brilliantly illustrates the pathognomic structural deformities caused by GUTB. You'll see the presence of sterile pyuria, and anatomical remodeling like an indrawn golf hole ureteral orifice, or chronic transmural fibrosis leading to what we call a contracted thimble bladder.
What is the most appropriate initial therapy to delay skeletal complications like spinal cord compression in a patient with advanced, poorly differentiated prostate carcinoma? A. Radiotherapy, B. Chemotherapy, C. Hormonal therapy, D. Prostatectomy, or E. Bisphosphonates. The first-line systemic management is C. Hormonal therapy.
You see, prostate adenocarcinomas are highly androgen-dependent. Androgen deprivation therapy, or ADT, works by rapidly clearing circulating testosterone. This hormone suppression cascade induces widespread apoptosis of malignant cells, shrinking the tumor and dramatically delaying those catastrophic skeletal events. Medical castration is typically achieved using an oral antiandrogen combined with LHRH or GnRH agonists. Note that while focal radiotherapy is highly effective, it's reserved for local palliation of existing pain, not as a systemic preventative strategy. Which of the following is a classic, high-yield diagnostic hallmark of advanced renal tuberculosis? A. Cobra head filling defect. B. Acute colicky flank pain. C. Palpable flank mass. D. Persistent sterile pyuria. Or E. None of the above. The hallmark here is D. Persistent sterile pyuria.
Sterile pyuria is essentially the presence of active white blood cells, pus cells, on microscopy, but with completely negative standard aerobic bacterial cultures. This incredibly deceptive clinical picture happens because Mycobacterium tuberculosis just cannot grow on standard agar media. It requires specialized, slow-growing cultures. For your exams, remember that a cobra head sign on an IVP points to a ureterocele, not tuberculosis. And make sure you always distinguish GUTB's constant dull loin pain from the agonizing colicky waves you'd see with acute nephrolithiasis.
A 57-year-old male presents with severe obstructive symptoms and unremitting low back pain. Staging confirms advanced prostatic adenocarcinoma with osteoblastic metastases to the lumbar vertebrae. The most effective palliative option for targeted pain relief is A. Radiotherapy, B. Chemotherapy, C. Corticosteroids, D. Prostatectomy, or E. Bisphosphonates. The palliative answer is A. Radiotherapy.
What's really interesting about this is how focal external beam radiation targeted directly at the involved vertebrae debulks the local tumor mass right within the bone marrow. This provides rapid, substantial pain relief. Also notice that prostate bone metastases are uniquely osteoblastic or sclerotic, meaning they cause dense, abnormal bone deposition. If our patient had widespread multifocal pain instead of just localized pain, we'd reach for systemic bone-seeking radiopharmaceuticals like strontium-89 or samarium-153.
An elderly male undergoes a monopolar TURP. In the early post-op period, he develops altered mental status and generalized tonic-clonic seizures. The most likely metabolic cause? A. Dilutional hyponatremia, B. Hypernatremia, C. Hypokalemia, D. Hyponatremia, or E. Hyperkalemia. The answer is A. Dilutional hyponatremia.
This sudden, scary neurological complication is transurethral resection, or TUR, syndrome. During a monopolar TURP, the open prostatic venous sinuses can massively absorb the hypotonic 1.5% glycine irrigant. Absorbing liters of this non-saline fluid causes acute dilutional hyponatremia, literally driving water into the brain and triggering severe cerebral edema. For mild symptoms, we use diuretics, but for severe neurological signs, like seizures, we must step up and cautiously administer 3% hypertonic saline to halt cerebral herniation. And as a surgical rule of thumb, always limit monopolar TURP to less than 60 minutes.
What's the preferred irrigation fluid for modern TURP to minimize the risk of TURSP syndrome? A. Normal saline, B. Lactated ringers, C. 5% dextrose, D. 1.5% glycine, or E. Sterile water. The modern surgical solution is A. Normal saline.
So the crucial point is understanding the difference between monopolar and modern bipolar circuits. Traditional monopolar TURP strictly requires a non-conductive fluid, like 1.5% glycine, to prevent the electrical current from dissipating. That carries the high risk of TUR syndrome we just talked about. Bipolar TURP, however, keeps the electrical current localized right on the loop tip. This safely allows surgeons to use conductive, isotonic normal saline as the irrigant. Because it has physiologic sodium concentrations, systemic absorption doesn't cause dilutional hyponatremia, practically eliminating the risk.
A 58-year-old male presents with obstructive urinary symptoms, significant weight loss, and constant low back pain. A screening ultrasound is inconclusive. The most appropriate initial investigation? A. Bone scintigraphy, B. Serum PSA, C. Trust biopsy, D. Urinalysis, or E. CT scan. The most appropriate first step is B. Serum PSA.
While his urinary symptoms could be benign, the unprovoked weight loss and constant back pain are massive red flags for advanced prostate carcinoma with bone metastases. A serum prostate-specific antigen, or PSA level, is the safest, minimally invasive initial step before rushing into a biopsy. Let's look at the tiers here. Less than 4 is generally normal. 4 to 10 is a gray zone. Here, a free to total PSA ratio of less than 18% points to cancer. Greater than 10 is highly suspicious, and greater than 35 is highly diagnostic of advanced or metastatic carcinoma. I'll leave you with this provocative thought. What underlying cellular mechanisms cause the PSA to spike exponentially once metastasis occurs?